All right. Well, this is Jennifer Cock. Peg, are you able to hear me?
I can hear you just fine.
All right. Well, perfect. I have started our recording, so we can save this for the others. We have a huge group. We have, looks like, about 49 different lines on. We extended the invite to our partners in Iowa, so we have some hospitals from Iowa and then hospitals from South Dakota. So I welcome everybody. I'm Jennifer Cock. I'm an RN Improvement Advisor through the Compass HIN, employed with SADAHO here in South Dakota, our hospital association. And this is going to be a great webinar to kind of set the tone for 2020 with your NHSN reporting. And so we have Peg Gilbert on the line. She has been our consultant for the last 3 years and kind of our NHSN expert and guru. And so we've asked her to once again for, I guess, the third year in a row, give us a little update on the changes, the updates within the patient safety module, and then touch on that survey that we all have to have completed by March 1st. And then a little time at the end for some case study reviews as we kind of continue to educate ourselves on criteria and how to enter events. So Peg, I will mute myself, and I do have all the other lines muted, so we shouldn't have any background, but if we do, I'll jump in and assist with that. Thank you, Peg.
All right. Thank you, Jennifer, for asking me to speak to all the people in South Dakota and my original home state of Iowa. I was born in Iowa, so I consider myself an Iowegian, even though I've lived in Nebraska much longer. I titled this particular presentation, How Time Flies, simply because it has been 10 years this year that I've been regularly teaching NHSN, and I can't believe that it's been that long. And it's really changed dramatically from its original use, where it was a voluntary database for people that wanted to benchmark for infection control purposes, to now it's being used as a mandatory database and used for prospective payment also. So that has certainly heightened everyone's interest, and definitely there are about 1,500 people, facilities enrolled in NHSN when I started, and now I think there's over like 28,000. So it has grown dramatically. So the objectives of today that we're going to look at are, what are the steps needed to set up for the 2020 reporting year? And we're going to identify some significant changes in the National Healthcare Safety Network, or NHSN, definitions for 2020. And I underline significant changes because there are more changes than what I can possibly talk about in an hour webinar. But I've tried to highlight the ones that I really think are going to make a difference in the way you work with the database and the definitions. We're going to look at how to accurately enter measures using the new criteria, and hopefully improve your surveillance for the patient safety component for acute care and critical access hospitals. So let's get started. Every year it is required that you do a patient safety annual survey. This is what the 2020 survey looks like. It is actually in the system considered to be your 2019 annual survey, but the form says 2020 survey on it. So that's always a point of explanation there too, that you're using the right paper form, and that when you go to enter it, that you're entering it as your 2019 annual survey. The surveys are by component and service. And so what I mean by that, if you're enrolled in more than just the patient safety component, which we're going to be talking about today, such as the healthcare personnel safety or some of the others, then they have their own particular surveys. And also, if you're enrolled in other things like the long-term care portion or they have their separate survey. This update must be done. The survey must be done by March 1st of every year. However, I encourage PPS hospitals, or what I mean by PPS hospitals are those hospitals that are paid on a DRG basis and are required to report to CMS several of these measures, that they do this by February 15th, because your annual survey is based on several of your benchmarks for your measures that you're going to submit for third quarter 2019 are based on what your survey is, and we'll look at that for just a minute. So you want those measures to be based on your most current information, and then your benchmarks will be more correct. You're unable to add reporting plans if you don't get the survey in, and only through February. And so that's why that's the stick that NHSN holds over you and making sure that you get the survey done. You don't want to complete your survey until after the update. Well, the good news is that the update was done over the weekend, and they just released the information yesterday that now, after this webinar at 1 o'clock, you can begin doing your annual survey and doing all the things we're going to talk about. It's called your 2019 annual survey because you're using 2019 year data. You use everything from your 2019 numbers so far as admissions and beds and things like that. This information is critical because it determines the risk adjustment for your benchmarks, because your data will align with that survey that you have in there. And really an important factor is this survey is a lot of information, so you should not do this survey alone. So where do we find the survey format? It's going to be at the NHSN website. This is a screenshot of after you go into the website, not the database, but cdc.gov/NHSN. There is, you click on the tab that says reporting hospitals and then acute care hospitals, and then you get the same format for each of the measures: training protocols, FAQs, and data collection forms. So if you click on data collection forms, it will open up, and then you will see where it's located, your patient safety component annual facility survey form January 2020. And right below that is also an additional PDF that line by line, it gives you a table of instructions on how to complete that survey. The annual survey is critical, as I said before, because it impacts your benchmarks, because based on what you say for example, the correct C. diff test that you're using changes what credit you get for your C. diff cases. Your medical school affiliation makes a big difference too. So those are just a couple examples of what really changes. Last year when I did this particular presentation, I spent probably 25 minutes of the hour on the annual survey because they did a dramatic overhaul on it last year. However, this year I won't be spending much time on it because really minor changes overall. And I've just written a few of them down here in the neonatal section. It's just that question 30 is more specific. The antibiotic stewardship practice, question 35 was changed. Water management section mainly rewrote these particular questions simply because they weren't getting the answer that they wanted from them, or they were getting a lot of questions into the helpline about them. A couple of questions have been retired, one in the neonatal section and in the antibiotic stewardship practice section. So if you have your last year's one, it's going to be very helpful. I just want to review a couple of the confusing questions, especially for critical access hospitals. Question 25, if you do not deliver babies in your facility, it needs to be in my facility does not provide neonatal patient care services. And if you check NA and that's the case, you need to skip questions 26 through 30. And then questions 26 and 27 continue to be confusing to people. What an outboard admission is a baby that is transferred into your facility. So on question 26, inborn admissions and outborn admissions, that total number should equal the same number of babies that you include in question 27. So if you have 300 babies answered for 26, then 27 of all the different weights should add up to 300 also. Remember to include only level 2 nursery, not level 1. So if you only have a well baby nursery, you would be you would not enter those here. Okay, what is the difference between a level 1 and level 2? And I thought I'd just put that in the slides for you. And a lot of it has to do with the age of the babies that you will deliver knowingly. It is important that you, if you do deliver babies, that you have a nursery location in your system, even though you really don't have a room that you call a nursery because you do all rooming in, you still need to have a nursery location. And I'm mentioning this simply because of the number of facilities that I go out to in different states. This continues to be a problem in their setup, is that they don't have a nursery because they say, well, they're always with their mother. Well, they still have to be counted as a patient and in a nursery location. And you just use the number of bassinets you have for your bed size as your number. And this continues to always be a question of a lot of people on how do I handle my inpatient rehabilitation facility. And that this is for people that one portion of your facility are designated inpatient rehabilitation beds. And they have their own Medicare number or CCN number. And that number in the middle has either an R or a T. Because they are a part of your hospital, they are included in your number of patient days, your number of admissions, and in your number of beds on your hospital survey. However, you still have to do an inpatient rehabilitation survey. And where the beds go is where that bottom arrow is under all other inpatient locations. So the only time that you would not include them is if you have a freestanding inpatient rehabilitation facility outside of your hospital. Okay, how do I enter that annual survey? You're going to have an alert button now on your home page when you first log in. You can click on that button and it will take you to the survey. However, another way of doing it is on your blue bar that should look familiar to you. You can go to surveys on it where the arrow is pointing and select add. And when you select add, you will get the box that's right next to it, and that will come up with your facility ID, or if you have several facilities, you would select which facility you're going to do the survey for. And then the survey type is that FACSRV-PS, Hospital Survey Data, which means your Facility Patient Safety Survey. And the survey year, remember, is 2019. So remember, you're completing the 2019 survey. Admission and patient days are all 2019 numbers. Your number of beds are those that are set up and staffed beds only. They may not be your license number, but it is your number of beds that are set up and staffed. Be sure to scroll to the bottom of the form and click Save so that all your work is not in vain. And the data is saved only when it is complete. So you must complete all the required information, all the red asterisks. That's how NHSN lets you know what is required information before it will save. So you need to gather all you need to run off a copy of that survey, have it completely filled out before you go to enter it. If you want to see what last year's survey data information was, especially since this year's survey hasn't changed much, you can go to that same place under surveys and do find, and on that you can find your patient safety survey and scroll down, and you can print that off, and that can also help you know what you wrote before. I do want to caution though, if you enter your survey data and you want to change it, you realize after you've already entered it that something on that was not correct, you can also go to find and then select edit, and then you can make the changes to make it appropriate. I just want to caution those that are PPS hospitals though, if you edit a past survey after a submission date, your CMS data will not be changed. So once NHSN, if you do your survey prior to that February 15th deadline for third quarter 2019 data, It will be based on that survey. If you change it after February 15th, even if it's before that March 1st, your CMS data will still be based on the way you originally did that survey. So it's really important to have it totally complete by that CMS deadline. So annual survey tips: budget at least 75 minutes to complete the facility survey. When you go to enter it, print off a copy of the blank survey form and make sure you do complete it on paper first. Identify the individuals within your organization that may need to help you on specific questions, such as your lab director, your neonatal director, your antibiotic stewardship person. These are all key individuals that need to help you answer these questions. Use the table of instructions if you get stuck on a particular question. These will give you the details of what they're looking for. You do have to complete it in one sitting, and remember that deadline is March 1st. Okay, that's all I'm going to say about the survey, because as I said before, there's not much so far as changes from the previous year. So what we need to do after we do the survey is really reflect as we're going forward now on what we need to do to set up for 2020. What happened in your facility this last year? Did you gain any new services? Did you do any new construction? Did you take on any new physicians that you have some service lines that you didn't have before? All these need to be accounted for as you plan for 2020. So one of the things we need to verify as we're making sure that our system is set up correctly is that we have accurately in the system who our NHSN facility administrator and primary contact is. That is really important because that is who NHSN, when they have critical emails, that is who they're going to send that information to so that you can stay up to date. And if they are not correct, you've had a change in contact information. For example, I know a lot of hospitals this year got new EMRs, and some of that came with new email addresses. You need to update your contact information so that they can get a hold of you. And below, under facility, on your blue bar, you need to click on facility information, and then you edit your facility information by the contact information link. Your facility administrator, I have to say again, because I just worked through a process with this with the facility administrator left and did not reassign it to anyone else. And so that's a real problem. It's really important if a facility administrator is moving on or retiring that they reassign that role to someone who has NHSN access in your facility. Otherwise, you go through a lot of an ordeal in order to fill out a form, have your CEO sign it, and NHSN has to do all the changes, and it is quite time consuming. So make sure that your contact information is all up to date. You need to think then about your locations in your facility. Review your patient population to make sure that nothing has changed there. Are there any locations you're not using? If you're doing construction for relocations, there's some specific ways of handling that. And my best advice there would be that you talk to Jennifer, you talk to someone familiar with NHSN on sometimes you do need to change those locations, but a lot of times you should not, so that your information, the historical data will flow through when you do analysis. Have any of your changes changed to more chronic care versus acute care? Have you added, say, an inpatient rehabilitation unit or an inpatient psychiatric unit? Those need to be handled differently, maybe swing bed area. And I have a link up there of the resource which gives you all the location descriptions. How do you determine whether you should change a location or not? And because I always advise people, don't change locations if you can avoid it, except at the first of the year. And if you can't avoid it, then the 1st of July in 6-month intervals in order to keep your measures so that you can benchmark with them accurately. You choose patient mix to determine location determination, and NHSN wants you to use your acuity billing data to know what type of patient mix you have on a location. If you cannot use billing data, they want you to use admission transfer diagnosis. They would like for you to use a year's worth of data. If that's not available, at least 3 months, and to make every effort to collect a greater period of time than 3 months if possible. Where do I find the location description document? Again, it's on the NHSN website under supporting material, and the link there is CDC location labels and location descriptions. That was again edited for 2020, and you can see that's the latest file that I am pointing to there. They added a new location. There's over 200 choices of locations, and that to me is one of the reasons why NHSN is such a good database, is because it does discriminate that way. Before, there were only 3 levels of neonatal intensive care. They have added a level 4, a separate level 4 NICU. This is only going to be applicable to probably just a very few hospitals. And these are, this is the highest level of NICU. These are those that are located within an institution with the capability to provide surgical repair of complex congenital or acquired conditions. This is the highest level of care. They've got all the specialists. A lot of times these are places that fly in babies and things like that. So if you're one of those, please look at that and consider the level 4 nursery. They did spell out a new key term of physician so that you know that in the definitions, when they talk about physician, it can be a physician or physician's designee, such an NP or physician's assistant. So remember, as you're looking at these locations, data from inactive locations, if you do inactivate them, will be sent to CMS if you do not remove them from your monthly reporting plan. So just inactivating them is not enough if they are in your reporting plan. After you do inactivate a location, you can't enter any new data. If you do want to add more data to it, you have to reactivate it and then enter it and then make it inactive again. Okay, now we need to sit back after we've done the survey, thought a little bit about what's the change in our facility, made sure that our contact information, our locations are all correct, and then think about what measures am I going to report this year. So we're going to decide this based on our state and federal requirements. Should be discussed with your infection prevention committee based on your risk assessment, as we know that's foundational for infection prevention. Any collaborative projects that you're going to be participating in, such as the HIN initiative. And then also think about what your facility strategic plan is so that you can help get the measurements needed in order to make that be successful. So our next step is then to add our monthly reporting plan. So from your blue bar, we need to go to reporting plan and then add the month and year. So we begin, of course, with January 2020. And then for the device associated section of the reporting plan, you need to enter each location that you're going to submit measures related to devices, such as CLABSI, UTI, ventilator-associated pneumonia. Those are all devices. So you have to select the location, and those should be in a drop-down file if your location was added correctly. And after you have put in that location and then put check marks by those measures you're going to follow, you can then click on Add a Row, and then that will bring up and your ability to add your next location and what measures you're going to add to that. Okay, then the next section is going to be on your procedure associated. So then you would put in which surgical operative areas that you're going to submit, such as colon or knee. And then after those are completed, you come to the part that always is most confusing for people, and that is the MDRO section, or the area that you put in C. diff measures or MRSA bacteremia. The confusing part of it is under location, rather than putting in a 3 north or a 5 south or that type of thing, your location for C. diff or MRSA bacteremia is facility wide in. So as you can see in the top box there, I have facility wide in, and then you put the which of the MDROs you're going to submit into NHSN, such as C. diff. And with C. diff, you want to then check all ID event for all specimens. And when you do that, the database will automatically fill in. If you have an emergency room in your facility, it should automatically populate in for you in order to add facility-wide in for C. diff. Because if you're doing facility-wide in for C. diff for your hospital, you have to also do your emergency room. Not only your emergency room, but if you have a 24-hour observation unit, you also have to enter data on it too. That's all considered part of your inpatient status. So this is what the screen would look like. On the top, I put in facility-wide in for MRSA bacteremia, so it dropped in the 24-hour observation area and also an emergency room area to complete. When you after you've completed your January reporting plan of all the measures that you're going to put in, make sure that you save it. And then you can go up and then add the next month. So you do reporting plan, add, and change this month to February 2020. And then you've got it made. For under device associated, you can just click on copy from previous month, and then go down to, and then that will fill in all the work that you did on those locations. And then you can go down to the procedure associated for your SSI reporting, do copy from previous month, and it will fill it in. And for the MDRO section, the same, and then you can save it. And I always encourage people to just go ahead and do a whole year worth of reporting plans so that you have them in there. And that isn't why, if you're having problems later, that data is not entering. So your 2020 setup summary is to print off a paper copy of that annual survey, distribute it to key information sources, complete that survey in the database, review your contact information, review and update any location changes, and set up your 2020 reporting plans. Then you are ready to report. As always, there are always new definition changes, and that's what we're going to spend the bulk of the rest of our time on. Just some general reminders that they had in the document about the changes, that if you do change to an electronic medical record, if you've changed to a new one, you need to go through at least 3 months of doing it manually at a location, comparing that to your new electronic record, and make sure that the two of them are matching within 5%. And if that's the case, then you can just go with your manual, go with your electronic collected data and feel confident that that is accurate. A clarification that they wanted to make sure that everyone had knew that when you're talking about admission date in the facility, it is the first calendar day the patient is in an inpatient location. That is hospital day 1. Where that gets confusing for people is as our emergency room waits sometimes have lengthened, Sometimes someone will be in an emergency room. They'll go to it at 11 o'clock at night, and they will sit in the emergency room and not get to the inpatient unit until the following day at 1 a.m. or 2 a.m. So if they went to the ER, say on January 1st, but actually didn't get to the inpatient unit until January 2nd, their first calendar day of admission is January 2nd, not January 1st when they were in the ER. One of the things that they do every year is update the NHSN organism list. This is the document that tells us what are the pathogens that cause urinary tract infections, all those types of things. That's found under the NHSN website under the supporting material tab. And right here is a huge Excel file that tells you what the NHSN organisms are. So what happened this year was a pretty big change. It's now version 9.4. They decreased the all organism list by 463 organisms, decreased the common commensal list by 80, the mucosal barrier injury list by 127, and decreased the urinary pathogen list, the urinary bacteria list by 452 terms. So my message here is that you need to make sure that when you get a culture result, say for a urine culture, that you check this list to see that it is listed there as a uropathogen, that it is truly a pathogen for a urinary tract infection. Okay, let's move on to some specific changes in the individual measures. This one I think is a fairly big change, and this is something that you're going to have to go talk to your lab person about if you don't know for sure exactly the type of test. This changed a couple of years ago on the bloodstream infection. This is the laboratory confirmed bloodstream infection, and this is the first definition for that. That definition is that if you get a positive blood culture, then you have a laboratory confirmed bloodstream infection. And it was based on if you culture grew out that pathogen, or they had added if a non-culture based testing methodology was used. What is a non-culture based testing methodology? Is one that looks at whether DNA is present in a particular specimen versus growing that organism out on a culture plate. So what they have done is saying that the culture is the gold standard here. If blood is collected for culture within 2 days before or 1 day after a non-culture based testing methodology is used, use only the result of a blood culture to determine whether a laboratory confirmed bloodstream infection surveillance definition has been met. So what they're saying, non-culture based testing methodologies are great simply because they're rapid. You find out if there's a pathogen quickly and help guide appropriate antibiotic use. However, sometimes they are different than what a blood culture is. And if there is a blood culture done also, you need to go with what the culture says. Now, and here is a screenshot of how that definition has changed in the protocol manual and has basically what I said from the previous slide. Now, the big change is the laboratory confirmed bloodstream infection 2 and 3. Before it said you could use culture or non-culture based technologies. And now it's saying you cannot use the non-culture based methodologies at all to meet these criteria. And remember, laboratory confirmed bloodstream infection 2 is the one where you have cultures from 2 specimens that have common commensals to it, or things that could be contaminants or some in your particular specimen. So here is what laboratory confirmed bloodstream infection 2 looks like. Patient of any age and has one of the following signs and symptoms, and then the same NHSN common commensal is identified by a culture from 2 or more blood specimens collected on separate occasions. As you can see, they've now taken out the option of a non-culture-based technology. So the moral of the story is you need to talk to your lab, find out what they're using on your blood cultures in order to give you the information. And you can only use cultures to say that if you feel that there are 2 common commensals that meet the criteria for laboratory confirmed bloodstream infection 2 or 3. And 3, the only difference is that is with children less than 1 year of age. Okay, so the way that you get your information is really important from meeting that past definition. Now, last year I talked about optional bloodstream infection risk factor fields, such as Munchausen syndrome, or if you're observing patient injection into a vascular line. And I just want to clarify that NHS has become very clear about it actually has to be suspected patient injection into that vascular line. It can't be that a confused patient that bites it, that pulls on it, that all those sorts of things do not meet this observation. This truly has to do with a situation of someone with Munchausen syndrome that this person actually was taking toilet water and pulling it up into a syringe and injecting it into her central line so that she could stay in the hospital. That's what we're talking about, and the hospital actually had video evidence that that was occurring. Epidemiology, I'm going to have a hard time saying that, but you can read it on the screen, as during a current admission, matching organism identified in blood from a site-specific specimen, and if there is group B strep in the first 6 days of life. So these are now required risk factors that if they have, that you need to mark. And these, if these are present, they do start a 14-day repeat infection time frame for a central line infection. Now, last year I said because they were optional, you put central line no, so that those did not go into your CMS data. This year they want you to say central line yes, and then mark any of these risk factors, so that and they will automatically remove those for you now that they're required to be answered. So the big change here is central line is now yes, and when you're reporting a central line infection, and then you would mark the risk factor that applied to it. But those are taken out of your analysis measures. Okay, moving on to surgical site infection and secondary bloodstream infection. These are 2 very helpful tables in the protocol manual to determine a secondary bloodstream infection. And why I wanted to point this one out is because it had to do with the definition for prosthetic joint infection. And because that's the one you do if you do SSIs on knees, if you're doing surveillance for SSIs on knees and hips. The definition you'd be looking at is prosthetic joint infection, and they have added how you can use a blood culture in there to meet that definition, and then that bloodstream infection could potentially be secondary to that surgical site infection and not a primary bloodstream infection. Okay, so let's practice a little bit, because I've given you a lot of information so far. So we have a patient admitted with a central line with a positive blood culture in the emergency room with Staph aureus on November 1st. Do I enter this into NHSN? So think about this, come in and immediately the blood culture is positive in the emergency ER? No, that would be present on admission. Does this start a repeat infection time frame? Why I'm bringing this up is, remember, present on admission does start a repeat infection time frame usually. What is the date of event? And remember how I said that they clarified date of admission is the first day to an inpatient unit. So if they were admitted to the inpatient unit on November 1st, that would be the date of event. Okay, let's say this patient had a subsequent positive blood culture collected on November 11th that identifies Pseudomonas aeruginosa. Do you now have a primary laboratory confirmed bloodstream infection? Okay, let's think about that a minute. We initially had a positive blood culture on admission of Staph aureus, and we didn't put that in because it was present on admission. Later, within that repeat infection time frame, that 14-day period, I have a second positive blood culture. Does that particular pathogen be part of that repeat infection time frame, or do I have a primary? Well, the answer to that is it depends, and that's why I did the scenario for you to think about it. You have to investigate that present on admission positive blood culture to determine if it is a primary or secondary to another cause. Let's do an example of that. Okay, this person comes in, and November 11th, they have the Staph aureus. You have your infection window period and a repeat infection time frame. And so if you do on the 11th then has Pseudomonas, and there's no other cause for that, then this Pseudomonas blood culture would be part of this, and so it would not be entered because this is a presence on admission. But let's look at this case where when you went to investigate this, you found out the Pseudomonas is from, this person had an open wound that cultured positive for Pseudomonas from the surgical site, and so that bloodstream infection was secondary to the SSI. And so a secondary bloodstream infection does not create a repeat infection time frame. So that Pseudomonas would not be, would be a primary laboratory confirmed bloodstream infection. It would not be part of the repeat infection time frame because this one was actually a secondary, the one that was present on admission. So that's something that you need to think about. It present on admission does still need to be investigated on whether it would start a repeat infection time frame or not. Okay, so that's just to plant a seed in order to think about that situation when you have present on admission bloodstream infections. Mucosal barrier injury, laboratory confirmed bloodstream infections are always difficult and confusing. And this is one very small section of laboratory confirmed bloodstream infection events that occur. So just as a little bit of a review, you must have a laboratory confirmed bloodstream infection. You have to meet that criteria before you can go the next step to see if there is an MBI. And what that simply is that the mucosal barrier or the gut is seeding the bloodstream. And that's why they have a bloodstream infection. And there are 3 ways of admitting that. But if you can't meet the laboratory confirmed bloodstream infection, stop. Don't even look at this section. Also remember that the date of event is the date of event of the laboratory confirmed bloodstream infection, not of the MBI event. So what they changed for 2020 is that the repeat infection time frame, when there is another organism that is not an MBI organism, because that's a whole set of gut organisms only, is cultured from the blood. It is not added to the MBI repeat infection time frame, and you don't change the event to a laboratory confirmed bloodstream event. And so this is always a little bit confusing. In this particular instance, this person had E. faecalis on the 7th day, and they met the repeat infection time frame for that blood culture. Okay, but this person had a staph skin culture here, and later a blood culture that matched it. So that's secondary. So that doesn't, the skin culture is what causes the repeat infection time frame, not the secondary blood culture. So you may want to have Jennifer or some help if you do come up with an MBI. Those are ones that we always have to talk through and think through a little bit. A very little change in symptomatic urinary tract infection changes, or these are your catheter-associated UTIs, clarified that less than 65 years of age to all SUTI or symptomatic UTI examples. And the thing that I want to clarify is that these are less than or equal to 65 years of age. So that means that a person has to be 66 in order to meet this change that we're talking about. And just a reminder, a UTI cannot be considered secondary to another site infection. A UTI is always a primary infection. So using fever in someone more than 65 years of age continues to be confusing. So to use fever as a symptom, the catheter has to be in place for more than 2 days in an inpatient location. So answer that yes or no. And it has to be in place or was removed the day before the date of event. So let's look at this scenario just a little bit. Take out your piece of paper, and 70-year-old patient with a fever of 100.6, so remember it has to be 100.5 or greater in order to be considered a fever, on day 2 and on day 7. The indwelling urinary catheter was removed on day 6. Can you use fever as the symptom in this patient? Okay. They are greater than 65 years of age, so that catheter has to be in place for more than 2 days in order to use it. So it was inserted here 1 and 2. So can you use fever in this particular patient from the day 2 example? No. So what would be the date of event for this person? If you said day 5, you would be correct. The day of the culture would be the first criteria that meets the definition. So this would be the date of event, and you can use this fever as the symptom because remember, still in place or was removed the day before the date of event. So it was removed the day before the day of event. And so this would not be present on admission. So let's practice another scenario. We've got a 75-year-old with an indwelling catheter admitted with pneumonia. A urine culture is collected on day 4, grows E. faecalis. Right back pain is noted in the electronic medical record the day before, and so that would set the date of event on day 3. Does this meet the criteria for a symptomatic UTI? Well, the catheter's been in for 2 days before, prior to the date of event, so yes, it would meet the criteria. And we have a uropathogen. So on hospital day 12, a blood culture grows E. faecalis, and yeast. Can this blood culture be added as secondary bloodstream infection? Well, we have E. faecalis. We have two things in it, E. faecalis and yeast in both areas. So we have, it would be in the secondary bloodstream infection window, because that is your infection window period plus your repeat infection time frame. The E. faecalis can, as a matching pathogen, can be considered a secondary BSI to that E. faecalis urinary positive urine culture, urinary tract event. However, you got to do something with the yeast. Okay, does this start a bloodstream infection, repeat infection time frame? I'm getting a little ahead of myself. No, remember that we said secondary BSIs do not start repeat infection time frames for the bloodstream infection. That repeat infection time frame is only for the urine. So what are we going to do with the yeast? It is not a uropathogen, and it doesn't match the urine culture, so it must be investigated as a primary bloodstream infection. So what you would have for events in this particular scenario is you have a urine culture with, you have a positive urine culture with E. faecalis with a secondary bloodstream infection, and then you have a primary laboratory confirmed bloodstream infection with yeast. Okay, what's different about the MDRO module? Remember, that's the area where we submit C. diff, or the new name, Clostridioides difficile. They added Klebsiella as one of the MDRO aeruginosa as to the CRE definition if you're using that section. Now, this is the big change I felt in C. diff. We had before, when using a multi-testing methodology, which more people have gone to simply because that's what the guidelines are recommending now, the final result of the last test is what is placed, is whether you determine whether that is a positive sample. And they clarified that the testing must be on the same stool sample. So very common to use multi-step testing. Use the last test. Even if the earlier one was positive, the last one was negative, then it would be a negative test, but it must be the same specimen. Makes a big difference of what you put down and what you select as your laboratory practice is the type of testing that you're doing, because they do base part your benchmark on that. However, this part is what was new information to me. They clarified the last test. So you have a facility that is using both NAAT, or nucleic acid amplification test, or a lot of us frequently think of that as being a PCR test, or EIA, which is a simpler test for C. diff during the quarter. During that quarter, the lab used NAAT set on 75% of the specimens and EIA only on 25% of the specimens. So for that particular quarter, remember how you have to enter when you put in your summary data for MDRO, you have to choose what test you're using every quarter. You would put in for that quarter, you use NAAT as your testing methodology. But this is the one that I thought was really unique. Example 2, at facility B, and this is what I'm seeing a lot of, they're using GDH plus EIA for toxin because it has to be a toxin test. And then if there's discrepant results, then they check it with the nucleic acid or the PCR testing to see if it is positive. Okay, so a lot of tests then are not getting to that level. And before, with that type of testing, what I was having and what I was doing with the hospitals that I help with, this is what they would have answered for what tests that they were using. However, in a single quarter, GDH plus EIA was used in 55% of specimens. The remaining specimens, 45%, had discrepant results and thus were reflex to NAT or PCR. So the appropriate response would have been that you put GDH antigen plus EIA for toxin versus this one, even though you are doing this, but the majority of the time you are using this particular testing method. And that is a new way of looking at this for me. And so if you in the past are using this, you need to have a conversation with your lab. What are you predominantly doing? And you may have to have that conversation with your lab every quarter. Okay, a reminder, it is the final test, and these are some examples of that here. You don't enter duplicates, and remember, it's a duplicate is within 14 days, positive specimen in the same location. So let's say that we had a positive specimen on September 1st, in the ICU, on the 6th in the ICU, and the 17th on 4 North, and on the 30th on 3 South. You would enter the 1st, the 17th, and the 30th. SSI, they've updated the operative codes, and so you need to make sure that you're using the correct list. They have one list that is just simply the new codes for 2020, and so that you need to get that to your IT folks if they are pulling those for you. They made a lot of code changes, 544, but 54 of them are colon changes. And a lot of people follow colon. That's a CMS requirement for PPS hospitals. And they also made several CPT code changes. There's a nice table. It's always hard to know whether something was a scope. If you have the ICD-10 code, if you look at the 5th character and see that it is either 4 or an F, it was a scope. They added a term for equivocal imaging. If something isn't definite when they do imaging, then you have to have additional documentation that there was treatment of an infection. And just as a reminder, for gross anatomical exam, you cannot use an imaging test. This is present at time of surgery. Just clarified that where you have to find the documentation is on the narrative portion of the operative note, and wound class is not a determination for presence on admission. These are some miscellaneous changes. They expanded SSI analysis, and you can look at this document. VAE, there were just very slight changes, and I won't review those simply because not as many people follow that in the interest of time, because I wanted to make sure you saw that there's a new metric out there called the adjusted ranking metric. I've been around CMS for a long time, and when I saw this, I went, oh, this is going to be a huge change. This type of reliability adjustment was incorporated into CMS methodology and used in their performance measurements since 2007 for hospital mortality. They like this particular metric because you can rank hospitals against each other much better. And the fact that they're introducing this into NHSN, my radar went up that if I had a crystal ball, I would say that this is going to be a change that's going to be used in the metric that's going to be used in the value-based purchasing programs and your pay-for-performance programs. The big difference is the numerator. It's a reliability adjusted event number. Besides, the denominator is 2. The big advantage, there's a table here for you. It allows for facility comparison. This is calculated for you in NHSN now, just for volume of exposure. This has been the big complaint of large hospitals, that it's not an even playing field. And this particular metric should adjust for that. It's displayed as a percentile, where the lower the percentile, the better. This is the graph that you're going to get in NHSN, and how you interpret this is that for CAUTI, for example, this means that 44% of hospitals did better than this particular hospital did on CAUTI. And this hospital, that all the hospitals that on SSI colon, they did better than only 9% of hospitals. So they are really not doing well on colons. The lower the number, the better. And if there's no data, that means that you weren't expected to have any events there. There's a new process to generate data sets, and you can put in the date, and that will really shorten the time. If you're only interested in looking at a quarter for analysis, only put in a quarter. And the whole way that you see, rather than a bar, it's a circle. And again, another year has literally flown by. The definitions are always changing. Be sure to get help in completing your survey. It's time to review locations, add your reporting plans, and utilize these new definitions. I know there is no time for questions, or very little. I'd be glad if you do have any, if you send any in to Jennifer. I would be more than happy to respond to them in writing. So Jennifer?